Hi, everyone. So it's a tremendous opportunity to get a chance to moderate this session and to introduce our speakers. Again, this is the bone marrow failure session, which, as Tanya introduced, is near and dear to my heart. I'm an assistant professor here at Stanford in our Department of Pediatrics and in our Division of Hematology, Oncology, Stem Cell Transplant, and Regenerative Medicine. And my research focuses are on bone marrow failure syndromes, Fanconi anemia specifically, and non-genotoxic conditioning. And today we will start our session with a talk by one of my wonderful colleagues and mentors, Dr. Rajni Agarwal, who is a professor in our department and in our division. Dr. Agarwal actually led our program for many years, if not decades, and has been a true champion of our efforts here at Stanford, and more recently has taken a lot of ownership and pride over our bone marrow failure syndrome program, and specifically our Fanconi anemia clinical trials. And it's been a true pleasure to work with her in that regard. This last year, she was awarded the Fanconi Anemia Career Award, which is a great opportunity for her to also get recognition within the broader Fanconi anemia community. So with that, I'll have her come up to the stage and give a talk on radiation and Busulfan-Free transplant using JSP191 antibody conditioning and TCR alpha beta T cell, CD19 B cell depleted grafts in patients with Fanconi anemia. Thank you.
Thank you, Anishka, for the generous introduction. And good morning. Welcome to the second day of the great symposium. And I am really grateful for the invitation. I'm really grateful for the invitation, but also excited to present the TCR alpha beta T cell B cell depleted transplant platform for Fanconi anemia patients, along with a novel strategy possibly to eliminate total body radiation from the conditioning that is so desired in these patients. So as you would see, in past 20 or 25 years, we've come a very, very long way in improving outcomes after transplant for Fanconi anemia patients. So this publication from Minnesota indicates the sibling donor outcomes over 90%, and alternative donor outcomes are not that far behind. This is a great achievement in past 20 years. As the fludarabine and other drugs became available, the outcomes have consistently gone better and better. The alternative donors here are, though, the unrelated donors and the cord blood donors. And that leaves a little bit of a room for expansion of the donor pool. So it has other implications, but here we will go that we all know that only 25% of the patients will have a sibling donor who is matched. And here we have a genetic disease. So of these fully matched siblings, not all 25% will be Fanconi negative to go for transplant. Then amongst the millions of volunteer donors for the NMDP and cord blood banks, we have a certain percentage of patients who will find a donor, and yet leaving a large portion or a large number of patients who still require an appropriate donor match, and especially for ethnic minorities, it becomes a really important point. And in those situations, the idea of using the haplo platform becomes very, very important. And in this particular platform, you have a parent who is a half donor. You could have a sibling who is a half donor or half matched, and we can do the graft manipulation to this group of people. It is not new to how we would do the graft manipulation, but those grafts could be infused into the patient safely and have successful outcomes. So we are actually removing the alloreactive alpha beta T cells and B cells to prevent the lymphoproliferative disorder. And then we are keeping the NK cells and the gamma delta T cells for faster immune reconstitution. Now, I will summarize that the TCR alpha beta T cell CD19 B cell depleted grafts have the mega dose of CD34 positive cells, which is over 10 million per kilo, to really cross over the engraftment barrier, eliminate the TCR alpha beta T cells causing GVHD, and preserve the gamma deltas NKs to help with engraftment, also fight with the infections, and increasing the donor pool. And the standard conditioning with these transplants has been with the total body radiation of 200, cyclophosphamide 40 milligram per kilogram, which is the optimized dose for Fanconi anemia patients, fludarabine, ATG, and rituximab just the day before we infused the cells. The first set of data came from Rome, and this data set has 24 Fanconi anemia patients. The first and the second graphs have the incidence of acute and chronic graft versus host disease, and the incidence of acute graft versus host disease is 17%. Of note, it's grade 1 to 2. None of the patients had severe GVHD grade 3 or 4, and the chronic GVHD was also not extensive. It's 5%, very manageable, looks great. Looking at the overall survival of 100%, 22 out of 24 patients achieved early engraftment. 2 patients needed to have a graft reinfusion. Things are great considering that we are dealing with the alpha-beta depleted haploidentical graft from the donors. So with that in mind, this is a very successful approach, increasing the donor pool and really not getting into many more complications. We opened this protocol at Stanford where if we didn't have an appropriate fully matched sibling donor, we would use a family haplodonor with the standard conditioning regimen of TBI, cyclophosphamide, ATG, fludarabine, rituximab as specified in the Rome protocol, and we have the TCRαβ CD19 depleted grafts. This trial is still open. We have treated 6 patients on it very successfully. Now, this trial was open earlier. We continue to still have patients on this. As the patients go on, we have more and more follow-up, and patients are doing well. But is that really enough? Where is the issue? The issue and the challenge that remains is that addition of TBI or busulfan in these regimens contributes to genotoxicity. And then acute toxicities and late effects are very prominent, including cancer predisposition, especially in a disease like Fanconi anemia, where there is a DNA repair defect, and cancer predisposition is a very, very important part of their late complications and management. So here we have a paper from Blanche Alter from 2018, indicating that would hope this would work, but indicating that patients who are receiving stem cell transplant with the inclusion of any of these agents have a many-fold increase in the cancer predisposition and a high incidence of solid tumors and carcinomas later in life as compared to Fanconi anemia patients who did not receive a transplant. So there is the unmet need that we have yet not addressed. And how do we go about really removing any of the TBI or busulfan from these protocols? So one of the alternatives, or we think, would be using an antibody-based approach. And in this, we are using an anti-CD117 antibody. Now, CD117 is the receptor. With the ligand SCF, it is really interacting for HSC survival, proliferation, and differentiation. And when the antibody interrupts this interaction, the stem cell survival, proliferation, all of that is affected, and the bone marrow niche is emptied for permitting the engraftment with the donor cells or maybe gene-corrected cells homing to this niche. Now, humanized anti-CD11 antibody causes transient depletion of human HSCs from the niches, and it is also changed its name to JSP191, or now known as Briquilimab. The preclinical work with this antibody was done at Stanford. Anishka is here in the room, and then there were other collaborators, Judy Shizuru and members of the team, who really took it upon them for many years to figure this out. Now, the very first clinical trial in severe combined immune deficiency patients was also led by us, and UCSF was a very important participating institution with us, looking at initial safety and tolerability of this antibody. So, Now we have actually combined the two approaches where we have the conditioning modified to avoid genotoxicity. So we have the Briquilimab antibody, which is going to deplete the HSCs and enable engraftment and avoid tissue damage. And then we have the optimized graft with TCR-alpha beta T cell and CD19 depletion and enriching stem cells, decreasing GVHD and infections. But that is not enough. Third important part of the trial is the very close PK monitoring of the Briquilimab, ATG, and fludarabine to understand the niche clearance and immune suppression, level of immune suppression. So with that, we opened a phase 1b/2a clinical trial. And the goal was to enroll 12 patients. The first 3 patients on 1B arm are already treated, and the phase 2A part of the trial is ongoing with the enrollment. The objectives of this trial are safety and efficacy of the approach, kinetics of engraftment, pharmacokinetics of Briquilimab, ATG, and fludarabine, regimen-related toxicity, incidence and severity of GVHD, and immune reconstitution. I will show you this schema. The top portion of the schema is the donor product preparation. The donors are mobilized with GCSF plerixafor. This is not news to you all in this room. And then the product is collected and then taken for manufacturing. The patients are prepared really with the antibody, Briquilimab. So we have chosen a fixed dose of the antibody. This is not a dose escalation study. The fixed dose is 0.6 milligram per kilogram. And then so that's on day minus 12. Day minus 10, we start with ATG, thymoglobulin, 3 doses, minus 10, 9, and 8. And then we have fludarabine and cyclophosphamide in standard Fanconi doses. There is no radiation or busulfan here because that is the intent to remove it. Now we are needing the fludarabine, cyclophosphamide, and ATG. Patients are immunocompetent. We need to make sure they don't reject. See, on day 0, patients receive a graft, which is fresh, and CD34 dose per protocol is in excess of 10 million cells per kilo, and TCR alpha beta dose is less than 1 times 10 to the 5 per kilo. The protocol has no prophylaxis of graft versus host disease, so no calcineurin inhibitors and other medications because alpha beta T cell depletion is working as our GVHD prophylaxis. So here we have the schema, and the inclusion criteria are pretty standard: Fanconi anemia, evidence of marrow failure, age over 2 years, and a consenting more than 5 of 10 HLA matched related or unrelated donor. The patients who have a eligible 10 of 10 matched sibling donor are not eligible for this trial. So where are we? So we have enrolled 7 patients on this trial. 1 patient is currently on treatment, which means that they have received the antibody uneventfully, successfully, and they are awaiting the infusion of stem cells. So they're receiving other agents right now. 5 patients are post-treatment follow-up. They are, you're going to see the data on them. And there was 1 patient that was withdrawn from the study early, partly during the pre-transplant workup. We have some suspicion about EBV reactivation or primary infection, so we wanted to wait. And so there was a little bit of that issue, so we withdrew that subject who was enrolled later. So that's where the 7 patients are. I'm going to show you only 1 PK in today's talk, and that is the Briquilimab, because this is an important part. The 5 patients who received the antibody, important thing to note is that this is a very steady, very predictable clearance pattern, and all 5 patients cleared the antibody prior to the day of transplant. And if I could translate into the numbers, somewhere before day minus 2, everybody had cleared the antibody in that dose. So having said that, we take a breath, and now we go forward to show you some data. And I'm going to request, and I'm going to actually hold on each slide for a few more seconds, partly because first I will show you the data on 5 treated patients on antibody-based conditioning, and then the 6 patients who received the haplotransplants with the radiation-based arm. So you have a little bit of a comparison of where we are going with it. We got lucky here that we have about the equal number of patients on each of these. So you would look at antibody-based conditioning, just primary patient demographics, young patients in marrow failure who have received a graft from either parent or a sibling. TBI-based conditioning, there are 2 young adults and 4 younger patients. Again, same situation. The donor is either parent or a sibling. Here, the CD34, so the graft and engraftment. So the graft, you see in these 5 patients on antibody-based conditioning, patients received a very adequate graft. Per protocol, every time we were able to exceed the CD34 cell dose goal of 10 million in each of these patients. The alpha beta T cell dose goal was less than 1 times 10 to the 5, and you would see that we did really great here with the graft. The engraftment is great because a neutrophil engraftment, as you would see, is within first 2 weeks. And what is amazing is that the platelet engraftment is happening exactly at the same time. So both neutrophils and platelets are engrafting, fantastic. And I'd like to say a word here that any of these 5 patients, their last red blood cell or platelet transfusion was in the first week of post-transplant. After that, none. So they did not get overly transfused with anything. Now, you would say, how did the other arm do, like the TBI-based conditioning? So here is the data. CD34 cell dose, again, we met the criteria. So we can manufacture these grafts very consistently. Of course, the technology is great, and our lab is fantastic. The alpha beta T cell dose again met the criteria well under the limit. And the neutrophil engraftment is same within 2 weeks, and the platelet engraftment is same within 2 weeks. Very comparable engraftment data and very comparable grafts that these patients have received. Okay? All right. Now comes the holy grail, is the donor chimerisms in these patients. So we have very strict donor chimerism monitoring plan for each of these protocols. You would see the engraftment is not only early, it's robust, and it's durable. So the longest follow-up in the first patient is 18 months, the shortest is 2 months, and engraftment across all lineages is over 94%, over 94%. So we are very excited to see these donor chimerisms in the antibody-based conditioning. And here you see the TBI-based conditioning, similar graft chimerisms are also very similar. So there are some patients who are in follow-up at least 3 years out. I just, for the consistency's sake, took the 12-month time point. These engraftments are across all lineages, very stable, very durable, and over 91%. So this is really comparable, I think, in my mind. Now, coming to the toxicity part. So the toxicity part with the antibody-based conditioning, we have seen mucositis, grade 2 to 3 on every single patient. They require pain medications, some enteral support, all of that. But we haven't seen any veno-occlusive disease of liver or even a mild suggestion of that. None of that is noticeable. Infections. We have given all the immunoablation and ATG. So infections, we sort of were monitoring or are monitoring very carefully. So the 3 patients who have shown here having various CMV, HHV6, or BK, the BK cystitis was one with the organ involvement. Others are transient viremias, either not needing much treatment or short course of antivirals, no prolonged antiviral therapy. Most patients really recovered very well and have done well. None of the patients have shown acute GVHD so far, and the chronic GVHD is in 1 patient, moderate skin and GI. That's patient number 3. Let's go to what did we do here. So again, very similar data. The regimen-related toxicity is mucositis, grade 1 to 3. All 5 patients has urea or viral viremias and BK cystitis. The 3 patients had acute GVHD of the skin, which is basically grade 1. No grade 2 or above GVHD was noticed in the acute setting. And in chronic setting, there is 1 patient with limited skin. So this is where the data is. There is far more dissection of this data that is going on, and hopefully at some point in future we'll be able to talk about how much of antivirals and all that patients needed. Now, none of these patients in either group had major bacterial or fungal infections. So at this point, I would like to make a few conclusions. One, it is feasible to manufacture the grafts on a very consistent manner. These grafts are resulting into safe and well-tolerated infusions. All patients have engrafted promptly within 2 weeks of transplant with stable and durable donor chimerisms over 94% in all the lineages. Briquilimab infusion is safe and well-tolerated in patients with Fanconi anemia. And inclusion of briquilimab is promising in eliminating the need for total body radiation or busulfan from FA conditioning regimens, which I think is an important point because we want to really not do any more damage to the Fanconi patients who already have a repair defect. Overall, the combined approach, the antibody with TCR alpha beta depleted grafts, appears to be feasible, safe, and effective. Of course, the work of this nature, we are so grateful for our patients, their families, and a very supportive Fanconi anemia community. They really are wonderful. Our clinical teams within the Hematology Oncology SCT division and Center for Definitive and Curative Medicine. I would like to really have a shout out for our coordinators, nurse practitioners, and all. They just do nonstop work to make all these things flow as smoothly. Lindsay, our pharmacist, is awesome. The clinical trials program is the steady hand that we cannot do these trials without them. Nivedita, Alicia, Alina, Hannah, Kristen, Gopin, everybody, Jen, thank you. And Anishka's lab and Alicia's lab have done a lot of correlative work, which I am sure you're going to see once we complete the trial. It's amazing work that they're doing. A shout out to our collaborators at UCSF and MSK, and the thankfulness for the support from the financial point of view, especially California Institute of Regenerative Medicine, FARF, Jasper, Miltony. So thank you very much, and I would take your questions.
Hi, Rajni. Great trial, obviously. I'm going to be a little provocative here.
Yes.
So we know that JSP-191 is a pure, I'm going to use the word myeloablator, even though it doesn't really probably completely myeloablate you. It's a pure space maker, right?
Yeah.
It doesn't do anything to your lymphocytes.
Right.
So I think the huge triumph here is that you've proven that you don't need TBI, which is a combination myeloablator, immunoablator, to get the grafts in. The Cy/Flu ATG is sufficient. But what we don't know is whether the antibody is actually doing anything, because maybe these patients are so aplastic that they don't need any space being made.
Yeah, and actually, Chris, I love to sort of think about this question. And I know that a lot of centers, especially in Europe, when I had given a very early talk on just 2 patients, said, oh, we can get the graft in with just immunosuppression, why do you need it? But look at the setting also. I think it's an haplo setting. The old data is on the other alternative donors where it is, I don't know if it applies. Now, if you look at Margie Macmillan's paper from 2014, where they tried to de-escalate the TBI in the alternative donor setting, the trial halted at 150 centigrade of radiation because they had graft failures and they didn't want to go any further. So I understand your question that what is the antibody doing, but is it the synergy between the Cytoxan and TBI? I don't know that. And Judy's lab is actually studying that after we started doing this work. So I honestly think that I'm not looking at the agents. Well, we look at the agents separately, but we also look at the agents together of what synergy they bring to the regimen and how it works. So I think from that perspective, it may be. Now, the second part I like to say in patients when we have done the pre-transplant marrow biopsies, their biopsy cellularities are anywhere from, I should include that data, anywhere from less than 5% to 30%. So it isn't like they are flat out less than 5% and there are no marrow elements seen. There are marrow elements seen. So there has to be some way to clean whatever that you have.
Yeah, the question, I guess the wonder that I have is we don't think of Cy as being a real space maker in a normal human being, but in someone with Fanconi, Cy may be damaging enough to be cleaning out the marrow on its own. So, I mean, I'd love to see some patients done without the antibody, with just Cy/Flu, ATG.
I don't think that I am there. I don't think I'm there yet, Chris. You know, just before this talk, you, me, and Mike were talking.
I suggest that UCSF arm is Cy/Flu only, and that's so we have the control group.
Well, but I actually would like to bring up the conversation, Chris, that you, me, and Mike were having just before the talk, that what do we do when we finish these 12 patients, which we will very soon, right? What do we do? Where do we take the trial? Do we say, as Chris says, to stop, not do the antibody, and be like, oh, I really believe in the synergy of Cy and TBI. I don't think we understand what each of these is doing. So I think we need to wait for some lab data to understand what is synergizing with what. But I think there is something there. I would say that. But the second part is, after these 12 patients, what would be the next step? I would say, look, sibling donor Cy dose is 20 milligram per kilogram. Alternative donor Cy dose is 40. If I could bring the Cy dose to 20 to be sibling donor, that would be an advancement in it. You know, I think as little dose as needed. I mean, this is my thought. I haven't talked to my group at all. They may have their own ideas. So conversation goes on.
So before, sorry to interrupt this, but I want to go back with Chris. There's only one way to prove without taking it away, and that is to actually do the antibody therapy with no TBI in the stem cell sources that Minnesota used, because they showed definitively when they backed off on their TBI, they had rejections. Mm-hmm. But the notion, and all of us have done a lot of alpha-beta transplants, and do you think it is easier to get an alpha-beta graft in than a cord? And I would say no. Alpha-beta is very prone to rejection, just like cords are. What's that?
No, I was just thinking, like, when we started the Fanconi anemia, the alpha-beta depletion in Rome,
Yep.
I recall we had 2 patients who were not well transfused, and they actually rejected. I had one Fanconi patient that I had to transplant 3 times.
Right, but the antibody is not doing anything for rejection. It's a pure space maker. It does not
Well, that could be true, but it's also probably the antibody may be doing more than we think. We just don't know.
Yes.
I think it probably does. The data exists, but we haven't put it together. So both the group of Carlo in Genoa and ourselves in London use alpha-beta depletion with no TBI and no antibody. And speaking just...
What are their doses in the prep? I'm just curious. Is it camp?
They are exactly the same.
Exactly the same.
I think the dose of fludarabine is a little bit higher. but the size is the same. It's only 40. And we use graph-alone ATG. And my perception, I'm saying perception because I don't think we have put the data together to know what we're doing,
We should.
is that
Yeah.
there is, I don't recall a rejection, but there is mixed chimerism,
Yeah.
which is not always easy to deal with. And interestingly, the mixed chimerism is T-cell mixed chimerism. So, yes, I would like to know what the antibody does. I agree.
So the mixed chimerisms in Fanconi anemia is not the best thing in the world because, you're leaving behind the recipient cells, and you have risk for myelodysplasia or AML. You want to be as close to over 90% as possible. So that is less than adequate outcome, I would say.
That you're right. Although what I don't know is, of course, whether we have had sufficient follow-up, because at least in my patients, the T cells do increase over time, and it may well be. I mean, I know that doesn't happen with a myelofraction, but if you mix chimerisms in the T cells, often over time you do become 100%.
Right. And, the other two pieces of data that we haven't talked about is the PKs of the ATG and fludarabine in these. So we are intensively having all this data. The ones we have, all 12 patients, we'll talk. And then the data from Anishka and Alice's lab to correlate all the biology would be fantastic. Maybe it will help us to understand what the antibody is doing or not. But I wouldn't want to end up after a transplant with the mixed chimerisms in a FA patient. If I have to use the antibody, I will use the antibody, which is better than ending up with mixed chimerisms.
Either way, it seems like for sure it's a no-brainer to want to optimize the fludarabine and ATG. That's kind of a no-brainer, and figure out how to give our antibody the best way possible. But I really like the idea of looking carefully at your data in considering how to really do the next step. I would love to lower the cyclophosphamide dose. That's an easy target if it's possible.
Yeah. This is great. Thank you. Other questions? Thank you.
So very, very nice talk and very provocative discussion. Clearly, lots more to come, hopefully in the future in this area as we continue to learn more and improve upon these regimens still. So our next speaker, I believe, is a virtual speaker, Pietro Merli from the Department of Pediatric Hematology, Oncology, Cell and Gene Therapy group at Bambino Gesù Children's Hospital in Rome, Italy. He is an attending physician there who will be speaking about alpha-beta T-cell, CD19 B-cell depleted haploidentical hematopoietic stem cell transplants for treating bone marrow failure syndromes and myelodysplastic syndromes. Can you hear us?
Yes, do you hear me?
Yes, we hear you as well.
Perfect. And can you see my slides?
Yes. Can you just put them into presentation view? We see.
Yeah.
Perfect.
Okay.
Perfect. Go ahead. Thank you.
So, good morning, everybody. It's really a pleasure and an honor to be here today. I would like to thank especially Alice, obviously, for the kind invitation. I don't know if she can see me, but I'm in her old office. So today, she asked me to talk about alpha-beta T-cell and B-cell depleted haplotransplant for treating bone marrow failure syndromes and myelodysplastic syndrome in childhood. So these are my disclosures. So as you know, childhood MDS is quite different from that of adults in terms of incidence, which is more rare. In terms of clinical entities, we have in childhood low-grade myelodysplastic syndrome or RCC, refractory cytopenia of childhood, and less advanced form. There is a strong association with inherited bone marrow failure syndrome and other predisposition syndromes. The genetic landscape is completely different. For example, we have germline mutation in GATA2 or other somatic mutation, which are not present or more rare in adults. And also the aim of the treatment is completely different because it's always curative in children, while in adults it can be just palliative. And in this review by Professor Locatelli and Professor Stram, they reviewed the current European indication to transplant, the treatment algorithm for childhood MDS. And as you can see, the indication is for a matched donor primarily, while an haplotransplant is indicated if you don't have a fully matched donor. Also, immunosuppressive therapy can be an option in hypocellular bone marrow entities, which are RCC, obviously, which are the more frequent, but the results are not so good as in severe aplastic anemia. Obviously, you know that there is an overlap between the two forms. Also, data in the literature are quite scarce for myelodysplastic syndrome. Here is a report from, again, EWOG MDS group. In this study, they wanted to investigate the role of GATA2, but you can see the outcome of the general population, and there is an influence of the type of MDS on the outcome, while the status of GATA2 is not affecting finally the outcome. Data on haploidentical HSCT in pediatric MDS is even more scarce. We have some reports of T-replete transplant with, I have to say, good results also because most of these patients were advanced form of MDS. And regarding T-depleted haplo, we have just few reports. For example, this of 2020 showing 9 patients with just 1 case of TRM and good outcomes. Obviously, you know the report by Michael Pulsifer and of the PTCTC trial, the US court. Here there were some patients with MDS, but they were not stratified over the acute leukemia patient. However, the results are really notable. As you well know. So in 2022, we published together with the group of Pavia, which is in the north of Italy, our cohort of 28 patients with myelodysplastic syndrome. Half were male and half female. The median age at diagnosis was 9.6 years and the transplant 10.2 years. Most of patients transplanted suffer from refractory cytopenia of childhood, while 2 had EB2 and 6 EB1 and 6 EB2 or AML. You know that the classification has recently changed, but this is quite used, so we continue to use it in the clinical practice. Regarding mutational status of the patient, 2 had a GATA2 mutation, 1 SAM9-like mutation, 1 RANKS1, and another a variant of unknown significance in ANKRT-D26. Regarding cytogenetic lesion, 5 had monosomy of chromosome 7, while 1 trisomy of chromosome 8. Regarding treatment before HSCT, 6 already received immunosuppressive therapy, 5 azacitidine, and 4 those with advanced form chemotherapy. 3 were in CR at time of transplant, while for the others, the disease was obviously present, and 2 had already failed a previous non-haploidentical transplant. Regarding transplant donor and transplant characteristics, median age of transplant of the donor was 41 years. It was the father in the majority of cases, and the sex mismatch was present in 54% of transplant, with a female to male transplant in 6 out of 15 sex mismatch transplant. The conditioning used was based on treosulfan for most of the transplant, those with refractory cytopenia of childhood, while it was based on busulfan or total body radiation for patients with advanced form. All patients receive serotherapy with grafalon, ATLG, which is standard for us. It's given at the total dose of 12 milligram per kg on days -4, -3, and -2, so very close to the transplant. Regarding graft composition, this is quite typical composition for an alpha-beta depleted HSCT with a so-called megadose of stem cells. Some patients receive less than 10 million of cells. Alpha-beta content was below 100,000 cells per kg. It was our threshold, tolerated threshold, and you can see the numbers of gamma, delta, and NK cells. So regarding graft failure, and this will I will come back on this also later. 4 patients had primary or secondary graft failure, 3 with RCC and 1 with EB2. And all were successfully retransplanted from the same or the other parent. And this is in line with also other report, for example, from the group of Newcastle, showing that alpha-beta is a suitable salvage option for patients with engraftment problems. We compared these patients with that affected by severe aplastic anemia and given alpha-beta T-cell depleted haplo at our center, and here you can see a lower incidence of graft versus host disease, although the conditioning obviously was different. But this speaks in favor of a correct and precise diagnosis, although this is not always easy prior, obviously, to transplant. So there are open issues. You have already touched some of them in the previous talk. And obviously rejection is one of them. And if you don't want to use other upload platform like Ticon one, we have tried the use of this monoclonal antibody, which is an anti-gamma interferon monoclonal antibody, because we have some data showing that, especially in the T-cell depleted setting, gamma interferon has an important role in graft failure. You know, this is a very focused meeting on T-cell depleted haplotransplant, and you know that these patients were rejected frequently. They have an acute or hyperacute rejection with high-grade fever, hyperinflammation, so resembling an HLH. And you can see that TCRαβ levels, which are specifically induced by gamma interferon, were high already at day +3 after transplant. And the Cincinnati group published 2 years later similar results in indeed a cohort of patients with bone marrow failure syndrome, and together with other biomarkers, they confirmed the role of gamma interferon via 6CL9. So for this reason, we started to use this monoclonal antibody that was developed indeed for the treatment of relapse or refractory primary HLH, and is currently approved in US, but unfortunately not in Europe. And so we put together a cohort of 31 patients treated across the ocean, the Atlantic Ocean. In Europe, we had a prophylactic approach. I mean, patients who were already rejected and were retransplanted, or those at a very high risk of graft failure, for example, for HLH. received imapalumab before transplant and continued until engraftment. While in US, the approach was slightly different. It was a preemptive or therapeutic approach. And when the patient had signs or symptoms of impending rejection, for example, high-grade fever, reduction of white blood cells counts, or biomarkers like an increase of 6CL9, they used high dose of emapalumab in single or double repeated doses. So first of all, safety. Safety was good because we didn't record any case of serious adverse event related to the use of the drug. And moreover, regarding efficacy, most of our patients engrafted. Obviously, this was a retrospective study. It was the cohorts are not comparable, so there was no a control arm. So we can't say much on efficacy, although some signals of efficacy are present. There is also the problem of anti-HLA antibodies, although I don't think this is so important, at least in pediatrics. However, for patients with high levels of anti-HLA antibodies, we applied a slightly modified protocol from the MD Anderson one using rituximab plasma exchange and the infusion of irradiated donor cell before the transplant. So patients who engrafted had a fast engraftment, and you know it. And again, the cumulative incidence of acute and chronic graft versus host disease was low. This speaking, obviously, it's important in a pediatric population. And again, obviously, the problem is that of infection, and specifically of viral infection, since more than 50% of patients experienced at least one viral infection, CMV being the most frequent pathogen identified, but there were cases of adenoviral infection and HHV6. One patient indeed died of CMV infection, disseminated resistant CMV infection. She was a patient with severe graft versus host disease after the second transplant because she rejected the first transplant, so a difficult patient. While two patients with advanced MDS had a relapse and eventually died of relapse. So at the end, cumulative, the overall survival probability at 5 years was 88%, and the event-free survival was 76%. The only factor associated with overall survival and disease-free survival, the presence of monosomy of chromosome 7. As you can see, this impacted importantly the outcome. I won't speak about immune reconstitution because Valentina Bertaina will have a talk on this later. And so I conclude this first part of my talk, while I'll pass to Fanconi anemia, which was introduced already in the previous presentation. So we have an experience with CD34 positive selected HSCT in Fanconi anemia. This is a cohort of 12 patients we transplanted in Rome and in Pavia. With a good overall survival outcome, but there were cases of, again, transplant-related mortality and rejection. And also this retrospective multi-center study seems to indicate that ex vivo T-cell depletion in Haplo was not as good as it seems from some reports. However, in 2022, we reported this cohort of patients that was already mentioned in the previous presentation. The conditioning, as mentioned, was based on SAI and flu and a single dose of TBI. And to answer, possibly answer to one of the questions raised in the previous discussion, the two of the three patients requiring further intervention, so namely a second transplant or a boost, were those two who didn't receive, for different reasons, mainly donor parent decision, the TBI. So it can be a case, but two of them had an engraftment problem. So I think that the antibody described before has a role, although obviously the effect is not so easily dissectable from the rest of the conditioning. All these 24 patients, and additionally, I am aware of a patient from Israel who was transplanted with alpha-beta T-cell depletion without TBI, and he rejected and was retransplanted with TBI. So there is a third patient that can answer to this question, although 3, again, it's a low number. So all these 24 patients are alive and disease-free. As already mentioned, 3 require further intervention, 4 had acute GVHD, 1 mild chronic GVHD, and 1 developed grade 2 vulval intraepithelial neoplasia. And these are the curves of the study. So recently, we updated our cohort and have also some other patient, again from Pavia and from Tokyo. And this was reported as poster at last ASH meeting. Now we have 35 Fanconi patients transplanted with this approach, with median age at diagnosis of 5 years and median age at transplant of 8 years. Most of them have had a FANC-A mutation, and the reason for transplantation was a severe bone marrow failure syndrome. So regarding the results, again, you can see that the poster of Daria Pagliara. Primary engraftment was achieved in 33 patients, while the 2 experiencing primary graft failure were, again, retransplanted from the other donor. So 9 developed grade 1 to 2 acute GVHD. 1 had lower gastrointestinal involvement. Another patient developed late onset skin only grade 2 acute GVHD, while 1 developed grade 4 GVHD with liver and gastrointestinal involvement at day plus 100, but this was 4 weeks after the infusion of adenovirus-specific donor T cells, and the patient already reported at mild chronic GVHD. These are the infection, again, important, but notably with a median follow-up of 5.5 years, all the patients are alive and with the resolution of hematological complication. Obviously, we have to wait and see for secondary neoplasia because of the conditioning of TBI, but at present, the results are good. So the third and last part of my talk will be on other inherited bone marrow failure syndrome. So I'm quite frightened to talk about this at Stanford, but okay, just touch some clinical data. This is a nice review in blood, obviously showing the characteristic of each of these diseases. And in Rome, so far, we have transplanted 14 patients with other IBMFs, plus don't shoot me, I added a patient with Niemeget breakage syndrome, not because it's bone marrow failure syndrome, but because it has some features of Fanconi anemia, and it goes in differential diagnosis with it. So we have 6 patients transplanted for Diamond-Blackfan anemia, 3 for severe congenital neutropenia, 2 with congenital megakaryocytic thrombocytopenia, 2 dyskeratosis congenita, and 1 Schwachman-Diamond syndrome. Obviously, the reason for transplant was the disease itself, just a monolinear cytopenia, while only 4 had severe bone marrow failure. The conditioning in this case obviously varied because, for example, for severe combined neutropenia, Schwachman-Diamond, we use a trio-based conditioning, while for Diamond-Blackfan anemia, we use Busulfan-based conditioning. Overall survival was above 90%, while event-free survival, because rejection and 1 death, was 72%. So in these last 2 slides, I put together all the patients I presented so far. So there are 80 patients in total, with an overall survival of 95%. And there was no difference when patients were stratified by diagnosis, and event-free survival was 80%. And in this case, there seems to be a trend, not statistically significant, toward a difference when patients were stratified for diagnosis. So to conclude, we confirm that this approach is safe and effective, also for children with MDS or inherited bone marrow failure syndrome, with Fanconi anemia being a notable example. Graft failure is lower than severe aplastic anemia, but still an important concern. Graft versus host disease is low. There are no data comparing this approach to that of other approaches like cell replete transplant. And obviously, to further improve the outcomes, there are several possibilities. One, obviously, is improving the conditioning with less toxic agent, like the anti-CD117 monoclonal antibody. Adoptive cellular therapies aimed at reducing the risk of relapse or for advanced disease, or restoring pathogen-specific adaptive immunity, as well as new infectious agents like letermovir or brincidofovir. So at the end, let me thank again Alice for the invitation and for her activity here in Rome before coming to Stanford, and all the different units of our department under the direction of Professor Franco Locatelli, the Center of Pavia and of Tokyo. Thank you.
So I'll moderate the session with questions here. Are there any questions for Dr. Merli?
Ciao, Pietro. You made me a little tear in seeing that office and thinking how much time I spent there and how much fun we also had around that office. As usual, very beautiful data and beautiful slides. Thank you so much for putting together these different cohorts and giving us really a big overview. Couple of questions. Graft rejection in general, and then in the non-malignant disorder, and then about some specific disorders. Yesterday, we had a great conversation about the role of ATG, specifically focused on thymoglobulin, which is the only formulation available in US at the moment, and how important is the cumulative dose, but also the distal start from with respect to the transplant to really reduce the risk of graft rejection. And then we saw some data from Europe, specifically on sickle cell and thalassemia, where also with Grafalon, the start of the first day of administration was moved more distally with the same goal. So I was wondering if you had any thought about that, and if you had considered to potentially move back the Grafalon in this group of patients, again, to achieve a higher ATG exposure at the time of the graft infusion. And the second question, correlated, it's really focused on patients with severe aplastic anemia. and HLH, which are not bone marrow failure, but behave in terms of graft rejection in a similar way. Those are the patients where I personally have PTSD from their graft rejection, and when we have to do one of them, it's where they convince me to do a cord. You know, that's a hard sell for me. And I'm wondering, how can we get in a graft in these patients using an alpha-beta T-cell depleted approach? Is the imapalumab prophylactic use enough, in your opinion? Are there other targets that we should consider? Because there must be a solution on how to really manage that inflammation. I know some of my colleagues here would say Campath might be the right drug instead of ATG in those particular cases. I just wanted to pick your brain and see what you think.
Thank you, Alicia. So very stimulating questions. So first one, unfortunately, we are just setting up now the dosage of ATG to have some in-house data, but we know there are many data from other groups. For example, I know that the German colleagues have some good data, and they are using ATG upfront in order, again, to have a very good exposure before the transplant, a low exposure at time of transplant, and they identified some dosage for grapholon, and they have some formula to calculate the optimal exposure. So they are wondering to have frozen transplant to be infused at the right time point when the ATG levels are optimal. But again, this is just speculation, but very interesting. But I fully agree that we have dosage of busulfan, we can optimize the dose, but we don't have so far a clinical grade application for ATLG, and this is, in my opinion, of utmost importance to optimize the outcome, especially in a setting like that of alpha-beta T-cell depleted transplant. Second question, graft failure. You know, it's one of my topic, the topic I like to discuss. I think it depends much on the specific disease you are treating. I mean, for example, for HLH, imapalumab could be enough, because the disease is based on this hyperproduction of gamma interferon, and I feel that if you have a good conditioning, then you can play a lot with imapalumab. The optimum would be that of having real-time monitoring of 6CL9, like in Cincinnati they have it. We don't have that option, so it's our approach is more practical. But again, since we don't have a problem of toxicity related to emapalumab, the idea in this specific disease, I mean, would be that of maintaining a high level of neutralization of gamma interferon, like how it's achieved in secondary HLH. Again, for other diseases, I mean, for example, thalassemia, we know that it's not so easy to transplant with a T-cell depleted haplo a thalassemic patient because of hypersensitization to alloantigen, to hyperplastic bone marrow, and so on. Probably there are other approaches. For example, one could be that of using ruxolitinib, but I think that we know not so much about the microenvironment of the bone marrow. We need more data on that to optimize engraftment. For example, I know that San Raffaele's group is working on that.
Hi, Dr. Merli. Chris Dvorak from UCSF. Great talk, and I'm going to be talking about some rejection issues in a little bit, and I cited several of your papers in my talk. I do want to push back a little bit on your comments about the patients with Fanconi who rejected when you eliminated TBI. I think your fludarabine dose is really low. 120 milligrams per meter squared of fludarabine is going to give you a cumulative AUC, if you have a normal renal function, probably in the 14, 15 range. It's way too low to really adequately T-deplete people. I'm going to talk a little bit about this in my talk. So I think you could optimize your fludarabine and still maybe get away from TBI, as Jose is doing in London.
Thank you. Again, I agree. We have to individualize the dosage of these drugs. I mean, I'm not an expert of TDM for fludarabine, but for sure we can optimize it as other drug. Again, I agree.
Hi, Pietro. This is Peter from Germany. Excellent data. May I ask you, which type of conditioning did you use in the patients who rejected?
Yeah, thank you, Peter. So usually, if the patient, this is quite empirical, we don't want to expose patient too much to fludarabine, but that's the corner of a second conditioning. If the patient didn't receive a cumulative dose above 300 milligram per square meter, we usually use, again, fludarabine with cyclophosphamide to optimize lymphodepletion. Again, because in this kind of graft failure, usually the mechanism is immune-mediated, and you have to immune suppress the patient so much. We usually change the ATG, so from Grafalon to Thymo, again, very empirically, and sometimes we add high-dose cytarabine.
Okay,
but no experience with Campat, which I think it's a good option in this setting.
Very nice talk. Congratulations. I have two comments. One is I think Chris and I could fight over it as much as possible, but I think what the point of the graft rejections, the two that you had in your series, and now TBI, I think it just highlights the fact that we need to understand immunosuppression and niche clearance better. That's all there is. So I am not so sure this is a point where we can settle it today or tomorrow. I think that we need to really have biology factored into it, and therefore the idea that once we complete the trial, we have all the PK data for everything, and other correlative studies would be a very great discussion amongst all of us. I think I invite you to all of us to that. That's great. The second comment I have is for the other bone marrow failures like DBA and Schwartzman diamond, the numbers everywhere are not that high. And is there a way that we all collaborate on a haplo protocol with the conditionings that we could agree upon, and that way we can have some meaningful work done in that direction? I think that me doing 5 patients and you doing some and Chris doing some or other centers would make sense. Maybe we come together as a group.
Thank you. So again, I agree with both the comments. So the first one, we need more data to dissect the influence of each factor. We know that transplant is such a complex setting with different variables, and rarely just one has so strong influence. One of the 2 cases who rejected didn't have a primary rejection, but a late secondary rejection with a mixed chimerism in T cells that increased recipient T cells, which increased over time, just to describe better. So regarding the second comments, again, I agree, we need more patients. We need to put together the data. Also because I think that DBA, but this is a personal opinion, but we share it sometimes with Alicia, that DBA patients are quite fragile, much more than what is described in literature. They have strange toxicities and so on. So I think, yes, we have to collect more data.
Yeah, I mean,
And happy to share them.
that would be great, because I honestly think that in DBA patients, would there be a role in some way for the antibody, because there's more to clear from the niche and reduce the toxicities in some ways. So anyway, I think the talk continues, and very interesting. Thank you.
Thank you.
And then Dr. Merli, I believe that there's one question in the chat. I can't see it. If you can see it.
No. Let me, because I'm no.
Okay, hold on. It's been handed to me. Okay, what other cytokines do you see to be increased or decreased that are also regulated by interferon gamma or inflammation?
Okay, so obviously also other gamma-driven cytokines like 6CL10. There are anti-inflammatory cytokines like IL-10. The profile is very, very similar to secondary HLH. I mean, we have a paper in Frontiers Immunology precisely describing the profile, but it's Th1 cytokines mainly.
Great. Thank you so much, and we really appreciate you joining today.
Thank you.
And then our last speaker of the series here is Professor Amy DeZern, who's a professor of oncology and medicine at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. And she'll be speaking about what about using PT-Cy for treating bone marrow failure syndromes. Please take it away. Thank you for joining us today. We appreciate it.
Good morning, everyone. Thanks so much for having me in that kind introduction. Hopefully you can see my slides now. All right. So just in the way of disclosures and a little introduction, I'm an adult hematologist who sees far more acquired disease than I think many in the room. I don't see as much inherited marrow failure disorders. And Alice was kind enough to invite me today because actually I do not alpha beta T cell deplete, but I'm really grateful to the learning I've already done from all of you yesterday and today, and looking forward to learning more. But hopefully I can share with you our experience using PT-Cy. So just moving a little bit away from Fanconi and some of what has been presented in the first two excellent talks, I know this group knows well that the main issue for acquired severe aplastic anemia is age of donor, access to donor, and whether or not somebody has the ability to get a transplant or to get immunosuppressive therapy. And these are the type of questions that we're continuing to try and answer. And in many of these algorithms aimed at practicing hematologists on the adult and pediatric side, there's rarely a comment in these flowcharts about conditioning or GVHD prophylaxis. And I love the awareness that this conference is bringing to this. In the transplant world, specifically for acquired aplastic anemia, I think really what we are measured against is a little bit different than some of what we've been speaking about earlier today. And I like this retrospective report from the CIBMTR as it's a comprehensive, pretty age agnostic, large series of a rare disease, in this case, acquired severe aplastic anemia of over 800 patients. And really what this study was looking at was rabbit versus horse ATG in a retrospective fashion for matched siblings. I won't belabor it, but I just mentioned that this is the measuring stick. And these patients were looking for robust engraftment around 90%, time to at least neutrophil recovery in the 3-week range, and low rates of chronic GVHD and high rates of overall survival for a quote-unquote non-malignant condition. And so lots of platforms, which this group knows well, have been built for these matched BMTs. The publications go back years and many wonderful work. And we're still continuing to, just as some of these most recent questions asked about, how do we dose attenuate, fludarabine, cyclophosphamide, TBI, even in the acquired setting? And as was mentioned a little bit more in the first talk, the use of alternative donors is something that we really have to think about in the current era of blended families, people of diverse backgrounds, and making sure everyone has access to a transplant. And that certainly is where PT-Sci really got its origins as much as the immunology and science, because here in Baltimore City, we have quite a underrepresented population, as the vast majority of the city is Black, and we needed to make sure that they could get transplants if possible. We learned that alternative donors in other settings, like the UK or in China, were increasingly acceptable, and we had to find out how to do it well. And specifically for aplastic anemia, it's taken 10, 15 years, but haplo-BMT in particular has been moving up in the algorithm. And I do think PT-Sci has a lot to do with that. But again, thinking about how we condition these patients. I think this audience likely knows well the history of cyclophosphamide. But I really think in this case, for the argument in this particular talk, that the use of haploidentical related donors that are readily available for our patients with, in this case, acquired severe aplastic anemia is really beneficial. And so PT-Sci in particular is particularly ideal for these non-malignant conditions like aplastic anemia. And using alternative donors that are there in the room with the patient or the recipient is the real deal, at least for us. And I'll show you some data leading to that conclusion. So if there's trainees in the room, just recognize it's always a marathon in academic medicine. This sort of slide represents my whole career, which is both sad or exciting, depending on how you want to look at it. But it started a long time ago, about a decade now, with our initial trial, and it's moved through various settings. And the work continues trying to make sure this is the best way to treat these patients. This is the regimen that we use for severe aplastic anemia, mostly acquired. I'll show you a couple inherited patients, but we do use ATG, fludarabine, and cyclophosphamide at the doses shown there. We use TBI at 400 centigrade for all, which I do believe are higher doses than my colleagues spoke about in advance of this talk today. And we always use a marrow graft. And then, of course, the traditional day +3 and +4, 50 milligrams per kilogram of post-transplant cyclophosphamide, along with MMF and tacrolimus to at least day 180. And I'll just mention, because this is a marrow failure session in general, to transplant MDS, we omit the green and we use a peripheral blood graft. So actually the bulk of my practice is patients in advance of 65 years with acquired MDS, and we treat them similarly. But the data today that I'm focusing on is aplastic anemia. So we have a lot of trials. We make sure they're eligible. In terms of comparing and contrasting to what you've already heard, we actually exclude Fanconi from these protocols quite purposefully for reasons the group knows well. We also have the benefit of being able to do flow fish in-house for telomere length testing, and we exclude those patients. And other inherited marrow failure, like the DVAs that were just alluded to and so forth, we think may need different regimens. Over the past 12 years, we've treated 88 patients identically to the results that I prepared for this talk, just so you could see the full repertoire. And this is actually the first time I've presented it all in aggregate outside of what's been published. We do use it on the pediatric and adult side. We use a range of related donors. This presence of clonality may or may not interest the group. We, of course, exclude monosomy 7 for aplastic protocols and standard of care aplastic transplants, but otherwise, a lot of PNH clones, 13q, trisomy 8. And as patients age, certainly I see a lot of clonal hematopoiesis that is not MDS defining. The majority of these are acquired, as I've alluded to, but about once a year, we might have a biallelic MIPL or some other very rare inherited marrow failure syndrome that predisposes to aplastic anemia, but is not the ones that are more frail, as we've spoken about earlier. And we do use the same conditioning, regardless of the state of disease or who the donor is. So relapsed and refractory, treatment naive, haplo, or in our case, we use this for fully matched donors now as well. What's very gratifying, and you've seen some of this before, is in all these 88 patients, regardless of state, their hematopoietic recovery is incredibly robust and rapid. And for patients, especially with very severe aplastic anemia, it's sort of a nail biter up until about day 17 when we start seeing a detectable white count. And it's very gratifying to get transfusion independence fairly rapidly for these patients as well. Certainly, it's not perfect. Before we augmented everyone to 400, we had some sepsis and we had a gentleman in his mid-70s, also with bacterial sepsis. They do tend to engraft, but we're not out of the woods yet. In terms of late complications, there was an EB negative diffuse large B cell in a 70-year-old man, 6 years post-transplant. Not sure if it was related. And in a patient in their 20s, there had been a known pre-transplant stomach lesion, but stomach cancer ultimately caused the demise. And how those latter two were related to this regimen, I think remains an area of thought. In terms of treatment naive, that's really where we learned, and I'll show you the data in a moment, about augmentation to 400 centigrade and working towards maximizing engraftment. It really is clear, and we've learned this in the sickle cell patients as well, that 400 centigrade TBI for these patients is superior, especially when they're treatment naive. It reduces graft failure and reduces death. And this was the early data that led us to fully amend the original protocol in the treatment naive setting. And once we have done about 40% of that 88 with 400 centigrade, you can see how we're doing and do have better overall survival at 3 years. Certainly, everyone knows that PT-Cy is a way to minimize graft versus host disease. That's what it was intended for. I won't belabor the science, but these are the global rates of acute GVHD and chronic GVHD, which really are quite favorable, especially, again, for disease where you do not need graft versus tumor and you don't want to exchange one quote-unquote non-malignant disease for the other. And very favorable GFFS using this regimen as well in this particular cohort here. Just wanted to show you to contrast to some of the data that's in the literature using this as an endpoint, though this was not the primary endpoint of the trials, which was overall survival. But this was what is pilot data for a forthcoming multi-center BMT CTN trial, where our endpoint actually is GFSS. I'll come back to that in a moment. So something in the acquired world that is important is survival. It's important in all worlds, but for this discussion, I'll just mention that we're often, especially on the adult side, quite held to a burden of immunosuppressive therapy, be that an ATG cyclosporin backbone or ATG cyclosporin and eltrombopag, again, on the adult side. And so the overall survival, as you can see here, is very favorable compared to even immunosuppressive paradigms in a recent randomized phase 3 RACE trial of patients with acquired severe aplastic anemia. So really something to think about when we're planning for transplant in someone who carries this diagnosis. We have pretty robust follow-up. As I mentioned, I feel like I have been doing this for quite a long time. And so all of these patients, as you can see here. And one thing that is different from an immunosuppressive paradigm is how quickly they get off immunosuppressive therapy, about 6 months, as opposed to the 2 years of cyclosporin that are often continued in acquired severe aplastics who received immunosuppressive therapy alone. And as we're just comparing and contrasting and thinking about if PT-Cy is the way to go for these patients, sometimes in the current system, we do have to think about cost. One cost is blood banking, and certainly the Red Cross is at an all-time shortage historically for blood supply. And the transfusion paradigm, and this is tabulated from 60 days prior to the day zero, so it may be imperfect, but drew that line through full engraftment and transfusion independence. So these are very modest amounts of blood, and I think probably less than what I tend to see in patients who receive immunosuppressive therapy. And at least in the state of Maryland, the costs are significantly less. Post-transplant cyclophosphamide is not very expensive. It's a very old chemotherapy, and I think that helps the process. Certainly, haplografts are often less expensive in some centers than unrelated or cords. And so again, something to think about as you're building your platforms. The other thing that I think is nice about this, and I believe I heard Dr. Pulsifer's voice in the room, he and I led the multi-center trial of this approach. And I think that shows that PT-Cy approaches are very scalable. We've known this for a while through other trials, but it's gratifying in a rare disease to see that we can extrapolate internal single institution data to a broader group. And what was really very heartwarming about this is this approach brought transplant to patients who had historically not been able to access it in the United States. We had pediatric and adult patients, but as you can see here, more than 40% of the population was non-white. And those were patients, especially in the severe aplastic acquired world, who historically got repeated cycles of immunosuppressive therapy and were unable to get to transplant. And I don't have them compared side by side, but you can tell from the curves I showed you of our internal patients treated in an experienced center, even when scaled to the multi-center setting, the results have overlapping confidence intervals. The overall survival was a little bit lower in the multi-center setting, but the GFS was also very comparable. And this was a heavily pre-treated relapsed population that overall did well. And I think as people gain comfort with PT-Cy-based regimens, this will continue to be something people offer to their patients. I alluded earlier to the fact that we use the exact same conditioning graft versus host disease prophylaxis for everybody with aplastic anemia. There may be some questions at the end, especially from the pediatric colleagues, as I think this was a little bit of a harder sell in pediatrics. But even with matched siblings, this is how we do it because we know we have very predictable engraftment and very low rates of graft versus host disease without a lot of relapse. And so we continue to gain that experience and treat uniformly. So I think the path to cure with PT-Cy for acquired severe aplastic anemia, as much as you guys know it, we can use any donor, and that's important when we're trying to move efficiently for a disease in very cytopenic patients. The overall survival is really good with this platform. It's certainly better than IST, and as one of the previous speakers noted, it's certainly never been compared head-to-head in any sort of randomized fashion with alpha-beta T-cell depletion, but it's something to think about. And I didn't extensively go through chimerism data, but the chimerism here is very predictable as well. It's once the graft is in, both compartments tend to track quite similarly in our hands and greater than 95% both in the whole blood and the T cell, which is how we do it. The toxicity is manageable, and we've already talked about the cost. And the multi-center study will be very important to see if we can establish this for acquired patients as a better standard. But what is next? And I think stating, just because it's my opinion, that maybe this should be a universal regimen remains a question, and I have aquipoise about that. But the BMT-CTN 2207, which I know is going to be open on the adult side at Stanford because my co-chair, Sally Arai, has been part of the protocol writing team for this. So this is a treatment-naive protocol. It's the same regimen that I just showed you. It's two parallel arms of haploidentical and mismatched, unrelated. And so really it's about testing the platform and less about the donor source, trying to bring access of transplant to all patients with acquired severe aplastic anemia. The BMT-CTN has another protocol for inherited diseases, and as I'll show you, another protocol for acquired diseases, really to offer the entire aplastic community an option on trial, which I think is, again, very exciting and trying to advance the field. My colleague, Dr. Pulsifer, is running the Transit trial, which again is for acquired patients on the pediatric side. And this is just a contrast with the multi-center study of 2207. I think it's interesting. None of these are testing the alpha-beta T-cell depletion, but again, just trying to ask really relevant questions in the aplastic anemia space for transplant. This is actually a very classic design of a true great question, randomizing a patient between immunosuppressive therapy and a transplant, whereas I mentioned R is really testing this particular backbone. We're going to try and have outcomes that parallel where we can and just see what comes out of it. Our study should hopefully be protocol available in May, we're thinking, to the world, but more to come on that. So just to close out, a few additional comments on acquired versus inherited. There's so many similarities, and I alluded to the fact that I see essentially all acquired disease really by virtue of being on the adult side. Certainly we look for inherited predisposition, but most of my patients have antecedent counts that were normal, the presence of a PNH clone, and other things to suggest by the time they got to age 60 that this was acquired disease. And I feel pretty confident about this platform in that setting. But it's the inherited setting where this group that I'm speaking to knows much more than I, but I've really enjoyed the past two talks related to Fanconi and inherited MDS as well. And here at Hopkins, we're trying to learn how to do that better within the construct of what we know how to do well, which is PT-Sci. I really like this paper from Lisa McReynolds at the NCI, talking about how 7% of patients who underwent hematopoietic stem cell transplant for severe aplastic anemia had an unrecognized inherited disorder. And this is something I worry about a great deal, losing a wee bit of sleep. Here I give talks about PT-Sci and that people should get this type of haploidentical PT-Sci based transplant, but I want to make sure that it's the right people that get the transplant. And I think that whole marrow failure community is working towards recognizing this and doing a better job of our pre-transplant testing to make sure that we don't hurt anybody. Here, as I mentioned, we do always do telomere testing. Certainly we do chromosomal breakage and full genetic analysis with an internal platform for the known marrow failure predisposition genes, but we may be missing them. But the 7% that they saw, for the most part, it's this group in the green that had unrecognized marrow failure and unfortunately did less well in terms of transplant outcomes. And I think possibly, this is a much older cohort than the data I showed you, but these could be patients on a PT-Sci trial if we don't rule out the things that we know that regimen that I've showed you is too much chemo. So there's a clinical need in innovation. You've heard this already. And what we're trying to think about in concert with colleagues and here internally is to make sure that we're treating our short telomere patients, as has been alluded to extensively in the prior two talks, limiting alkylators and radiation doses, and always including haploidentical donors where possible, and lower PT-Sci. As some of you might imagine, there are certainly people here very entrenched at the 50 milligram per kilogram per dose for all the right reasons, because it's historically what they know. But I think we can take a lot of lessons from our FA colleagues. The telomere-mediated syndromes, we see a great deal here. That's partly because Carol Greider and Mary Armanios are here, but also because we do the FlowFish testing mostly for the United States in a CLIA-certified way. And there's a lot of fludarabine-based experience that don't use PT-Sci, and for a long time, this is the regimen that we've used. But my good colleagues are trying to expand on this. And I've learned so much from Carmen Bonfirme in the Brazilian FA group and how to think about these patients with limitations of methotrexate and irradiation. And we're really trying to mimic their outcomes using unrelated donors for FA patients in the aplastic phase for both our short telomere and other more fragile patients like the Fanconi. And so what we are moving towards here is this style of paradigm where we know the drugs, it's similar to what we use in the acquired setting, and we're not a large Fanconi center, I own that clearly, but I've diagnosed 2 FA men in the last 4 months in their, one is in his early 20s, the other in his early 30s. And so we may be finding these patients more and more, and I want to make sure that we think about how to safely give them that PT-Sci backbone, similar to how they do in Brazil, and maybe even think about some of the trials and lessons we learned earlier today. What we have here is a short telomere protocol. My good colleague on the pediatric side, Heather Simons, has been running this for a long time. It's for primary immunodeficiency. And we are amending the protocol to very similar for short telomere patients, mimicking the FA patients, but tend to steer FA patients towards the exact Fanconi regimen that's used in Brazil. But we're going to try and use lower doses of Sci on the short telomere patients that have aplastic anemia to see if we can get the graft in, maintain that robust engraftment with minimal GVHD. So I'm really hopeful that the future will be a tailored bone marrow transplant for anybody who carries a diagnosis of aplastic anemia, regardless of the etiology. I think we need that communication in the field of standardized patient and donor testing. And then, as hopefully I've shown you, and will be points of discussion and perhaps even spirited discourse about whether or not PT-Sci is really scalable, how it's used in under-resourced centers, and then if it really is cost-conscious compared to other methods. Certainly it takes a village as we're moving from an older paradigm to a newer paradigm, and we're continuing to move forward. I'm grateful to you all for listening and for all my colleagues here in Baltimore, and I'm happy to take your questions. Thanks so much.
Amy, Gesù de la Fuente from London. I wanted to ask you, what is the incidence of macrophage activation, secondary HLH, threatened graft failure, whatever you want to call it, in your patient population, and how do you manage them?
It's a fair and honest question, and I'm quite sincere in that we have not had any in those 88 that I've showed you that would meet any of the criteria that you're referring to. We certainly see it, unfortunately, in other entities. A lot of our malignant patients in whom we don't use ATG and often use the peripheral blood graft as opposed to marrow. And we manage it, I think, dissimilar probably to many pediatric groups. We certainly use high-dose steroids, but not a lot of monoclonal antibodies, and occasionally eculizumab more in a TMA type paradigm.
Hi, Amy, this is Alice. Thank you so much for being with us. It's always such a pleasure to listening to your talks. Excellent data. One question and one brainstorming question. The question is about the chronic graft-versus-host disease. In my eyes of a T-cell depleted girl, when I see the data of the post-transplant side, what I'm always concerned about are the incidence of chronic GVHD, but mostly the potential severity of the chronic GVHD. So I just wanted to ask you, is that 6% is a mild chronic GVHD, or if there is any incidence of actually severe chronic graft-versus-host disease? And
so it's
yeah, sorry, go ahead. No, go ahead with that first.
I can't see you. Yes, you make a very good point. And of that 6%, which was out of the 88, there were 2 patients that had extensive. One was a child who we've long suspected maybe had an inherited disorder we didn't find. And ultimately he is well, but did go on to have a lung transplant because he had pulmonary chronic GVHD. And the other, while it did meet criteria for extensive, it was a middle-aged woman who's my patient who was on immunosuppressive therapy for about 18 months total. And then she's been fine ever since.
Thank you. I think this is really important. And again, we were discussing yesterday with Gesù about the hemoglobinopathies. I think that really that's the point to tackle. And I know in UK they are adding abatacept to try to reduce the risk of GVHD. And the reason why I'm thinking about that is because, again, when I think about our platform of T-cell depleted transplant, really severe aplastic anemia is a concern. I mean, I have not transplanted a severe aplastic anemia patient since I am here in the US with this approach, because I know that I'm going to give minimum a 20% risk of graft failure, which I don't want to take. And so we do post-transplant side here for severe aplastic anemia. Orly Klein is doing that. And then the parallel thought is, we know that much unrelated donor and 9 out of 10 unrelated donor are doing fantastic. But again, when I see those data are doing fantastic too. And so like a little bit like in leukemia, are we at the point of maybe have to randomize between unrelated donor and haplo post-transplant side, because maybe our haplo post-transplant side is the best way to go. But what can we do to one question to you is really, what can we do to optimize that post-transplant site so that we have less chronic GVHD? And the challenging question for this audience in the room, do we really want to abandon the alpha-beta T-cell depletion for severe aplastic anemia? Or can we come together with an approach that can reduce the risk of graft failure? Because that's the obstacle. While at that point in those patients, acute and chronic GVHD is not an issue. So we really need to tackle the graft failure.
You bring up a lot of good points and things that keep me up at night. To the first comment about a randomized trial, the BMT CTN 2207 is not randomized. As I alluded, it's 2 parallel arms, but I'm hoping that it's an excellent amount of data, that the statistics were written very carefully such that the data can be combined or compared if certain criteria are met. And it's not going to fully answer the question in the most classic sense, but I think it could either justify or not justify taking that, let's say, unrelated versus haplo to the next step. In terms of the other questions about graft rejection, I don't know that I have the answer. I think that our platform is really very, very consistent at getting the graft in. And the way we mitigate the longer term complications is something that the field does need more efforts towards.
Amy, if I could follow on that, have you had any discussions within Hopkins about the possibility of adding abatacept onto PTCI? And if you haven't, do you have any views as to when abatacept should be initiated on day -1 or wait until the PTCI has been completed?
So we've had some casual, shall we say, water cooler conversations. Nobody has proposed it in a rigorous trial per se. My thoughts are it probably can wait till after the PTCI, but I have no data in mouse or human to support that. I just think it probably can wait because I'm somewhat of a simplistic person. If it ain't truly broke, don't try to fix it. But that's just my editorial comment.
Thank you.
Hi, Amy. This is Rajni Agarwal from Stanford. Very nice data on severe aplastic anemia. However, my question is on the inherited bone marrow failure syndromes, and I actually am very excited and compliment Carmen for developing the PTCI in Fanconi anemia patients, because not every place can do the alpha beta depletion and not it's feasible for. So this is great. So at least we are able to decrease the dose of Psi in those patients, and that was a worry. But I still, when I'm looking at all the treatment regimens for telomere disorders and others, they still assign total dose of 50 per kilo and TBI. So it would remain to be seen how it goes in short term versus and also in the long term, because this is still higher. 40 is the highest dose we do for Fanconi anemia patients, and our goal is to bring it down to 20. So that's a concern, but again, I completely understand. Also, this is the first step towards doing something in PTCI arena.
So I completely agree, and I'll just make the comment that I have very carefully followed the Boston Children's data using no alkylator and no TBI for short telomere patients. And it's been published in abstract form, and I think it is solid data. Mm-hmm. But what you mention is really what we are trying to figure out here. And this is a feature of my being an adult hematologist, where I see the short telomere patients is 5 years after they successfully engrafted, maybe at Minnesota, and then they need their liver and their lung transplant. And I don't know if this is just the biology of the disease exacerbated by the conditioning, but the rates are the same when you look at TBI missing regimens and alkylator missing regimens. So I think we need a little bit better handle on the biology and maybe a totally different platform. Maybe we need to use the Jasper drug to not just make space, but not cause other problems, like was mentioned in the first talk. So I don't know, but I'm thinking about it similar to you.
Yeah, appreciate it. Thank you.
Amy, this is Jessie Alexander from Stanford. Congratulations on really stringing together some great work here, which can reach lots of patients. My question for you is, the data out of your institution is amazing, and the data in the trial is also quite good, but it's also not quite as good as your institution. So I had sort of one comment and a question. The comment is that I think in these patients with non-malignant conditions, continuing to look at the outcomes of severe GVHD-free, event-free survival is really what we need to look at in all these trials, and not overall survival, because that's really important for them in long term. What do you think could be one of the drivers of the difference in outcomes with extending this to more institutions, and do you see any way to make improvements on that?
No, I'll address your question in two different ways. So I hear you completely. And I mean this when I say I still have equipoise in many ways. And that's one reason that the BMT-CTN trial for treatment-naive disease is not overall survival. We need to show something that matters to these, not that survival doesn't matter, don't misunderstand me. We need to show what matters as well to these patients. And I probably didn't say this concretely, but the reason I strung the story together the way I did, or tried to, is that experience matters. And I think that's one of the limitations to scalability. 88 aplastic transplants over a decade is pretty decent volume for a rare disease, but it's not huge, even still. And for many centers, one transplant for aplastic anemia a year is all they do. And if this platform is not really familiar, there are nuances. Yes, you can follow a recipe, but maybe you just stir a few extra times and that's how it works. And one thing that was really a teaching point for me is we are a harvesting institution. We harvest all the time. And early on, and a lot of the detrimental outcomes in the multi-center study were due to low graft. Like one of the first patients that died had a CD34 count of less than 1 in the graft. And so we did a lot of teaching, and you could see the learning curve even over the trial. And I'm hoping to continue that momentum in the next trial as we again get familiar with the regimen. And that's why I think doing things consistently has merit. So that's not the most scientific answer, but hopefully it suits your question.
It's very helpful. Thank you.
So that concludes our session on bone marrow failure syndromes. Thank you to all of our speakers for joining, and to the audience for wonderful questions. With that, I'd like to invite our next moderator up to lead us in the next session on advances in leukemias. Thank you, Swati.